Kidney stones, also called nephrolithiasis, urolithiasis, or renal calculi, can form in the kidneys, but also in the ureters, bladder, or the urethra. They appear when solutes in the urine precipitate and crystallize. Depending on which solute precipitates to form the stone, there can be calcium oxalate, calcium phosphate, uric acid, cysteine, and struvite stones. Risk factors for developing kidney stones depend on their composition. Risk factors for calcium oxalate stones include high urine calcium, high urine oxalate, low urine citrate, and dietary factors include low calcium, low potassium, and low fluid intake, as well as a high oxalate and a high animal protein intake. Calcium phosphate stones usually develop in individuals with renal tubular acidosis type 1 and 2. Uric acid stones can form when urine pH is persistently below 5.5, which can happen with chronic diarrhea or conditions like gout, diabetes, and obesity. Cysteine stones occur in the setting of cystinuria, a genetic condition where too much cysteine is excreted. Finally, struvite stones, also called staghorn calculi, are made up of magnesium ammonium phosphate, and the main risk factor is a urinary tract infection with a bacterium that produces urease, like Proteus and Klebsiella. These bacteria increase urine pH, making it a favorable environment for magnesium ammonium phosphate to precipitate. Sometimes, kidney stones can be asymptomatic and discovered incidentally during an ultrasound or a CT scan. Other times, a kidney stone can cause symptoms due to urinary obstruction and renal distension. It can cause renal colic, which is when there's acute pain that's so intense that it requires IV pain medication. Passing a large stone through a narrow ureter has been compared to passing a baby's head through the vaginal canal. The difference is that you don't have to raise and nurture the stone once it passes. In renal colic, the location of pain depends on where the stone is located. A stone in the renal pelvis or the proximal ureter causes unilateral flank pain and tenderness, whereas a stone that's located lower in the ureter causes unilateral flank pain that radiates to the testicle or labia on the affected side. In addition, there can also be macroscopic hematuria, nausea, and vomiting. And if the stone is in the distal ureter, there may be dysuria and urgency as well. If the blockage is severe, like in a bilateral obstruction, when there are stones in both kidneys and they completely obstruct the flow of urine, or when a person has only a single functioning kidney, a solitary kidney, that gets obstructed, it can lead to signs of acute kidney injury, like anuria, which is when there's less than 100 milliliters of urine per day. A struvite stone can be accompanied by a urinary tract infection, which causes symptoms like fever, frequency, and urgency to urinate. Lab studies include a basic metabolic panel, where blood urea nitrogen, or BUN, and serum creatinine are done in order to check the renal function. With acute kidney injury, serum creatinine is elevated. Additionally, blood work and urinalysis may give clues as to the composition of the stone. Low serum bicarbonate and potassium levels may suggest an underlying renal tubular acidosis and a calcium phosphate stone. Serum calcium above 10 mg per deciliter suggests a calcium oxalate stone, whereas uric acid levels above 6 mg per deciliter suggest a uric acid stone. A urinalysis may show microscopic hematuria, or especially with struvite stones, there may be signs of a urinary tract infection, like bacteriuria and positive leukocyte esterase. On microscopy, if there are calcium oxalate crystals in the urinary sediment, this may point towards a calcium oxalate stone. Alternatively, with uric acid stones, uric acid crystals may be present. When urine pH is above 7 and there are phosphate crystals in the urine, this suggests a calcium phosphate stone or a struvite stone. Finally, hexagonal cysteine crystals are diagnostic for cysteine stones. The best way to see a kidney stone is by doing a non-contrast abdominal CT scan, but in pregnancy, an ultrasound is done instead. Now, on a CT scan, the location and density of a stone can suggest its composition. Calcium oxalate and calcium phosphate stones are radiopaque. A struvite stone is also radiopaque, but not quite as dense as calcium stones, and is usually large and located in the renal pelvis. Uric acid stones are lower density than both calcium and struvite stones. Finally, a cysteine stone is lucent, and it's barely seen on the CT scan. When an ultrasound is done, stones that are located in the renal pelvis and proximal ureter can be seen. The stones are easily identified on the ultrasound because they cast an acoustic shadow. Additionally, indirect signs of obstruction may be seen on ultrasound, like hydronephrosis, which is when the kidney fills up with urine and swells. Sometimes, a kidney ureter bladder radiography, or KUB radiography, can be done, and radiopaque stones like calcium oxalate and calcium phosphate stones and struvite stones that are larger than 5 mm can be seen. But stones smaller than 5 mm or uric acid stones and cystine stones are often missed. Now, treatment mostly depends on the location, specifically whether the stone is in the renal pelvis or the ureter, size, and composition of the stones. For individuals with acute renal colic, pain control is managed with an NSAID, like indomethacin, or an opioid, like morphine. During renal colic, IV hydration is avoided unless the individual is dehydrated, because it can worsen the pain. In some cases, urgent decompression of the collecting system may also be necessary following analgesia. For example, when there's bilateral obstruction caused by stones in both kidneys and acute kidney injury, or when there's obstruction of a solitary kidney, or if the individual presents with signs of sepsis, like with a struvite stone that's associated with a UTI, or when there's hydronephrosis and a secondary bacterial kidney infection. Decompression can be done with percutaneous nephrostomy, which is when a catheter is inserted through the back or flank into the kidney in order to drain the urine. Another option is ureteral stenting, which is when a cystourethropy is done. This is when a flexible tube is inserted through the urethra into the bladder. Once inside the bladder, the affected ureter is identified and a guide wire is passed through the affected ureter and into the kidney. A stent is then placed over the guide wire and pushed into the ureter, allowing the flow of urine. Now, if an individual's symptoms are controlled and there are ureteral stones that are less than 10 mm, then initial management is observation and medical expulsive therapy, or MET. MET includes increased fluid intake, at least 2 liters per day, along with an NSAID and an antiemetic like metoclopramide. In addition, an alpha blocker like tamsulosin or a calcium channel blocker like nifedipine may be used to help pass the stone. This is done for about 6 weeks. During that time, if the individual has uncontrolled pain, fever, nausea, or vomiting, or if the individual simply wants the stone removed, then a more aggressive approach is taken based on stone location. For proximal ureteral calculi, meaning stones located further up in the ureter, one option is extracorporeal shockwave lithotripsy, or ESWL. ESWL is a machine that uses high-energy sound waves that produce shock waves to break kidney stones into smaller fragments, which can then be passed in the urine. If ESWL fails, then flexible ureteroscopy, or URS, can be done instead. URS is also preferred during pregnancy. URS is done with an endoscope that's passed through the urethra, bladder, and finally into the ureter where it's used to remove the stone. For mid and distal ureteral calculi, and for all ureteral calculi larger than 10 mm regardless of their location, URS is done. URS is also the treatment of choice when lab work and imaging studies suggest a cystine or uric acid stone. If URS fails, then percutaneous nephrolithotomy or PCNL is done. PCNL is a minimally invasive procedure where a small incision is made in the flank, and then a flexible nephroscope is inserted and the stone is removed through the working canal of the nephroscope. Other options include laparoscopic or open surgery. Now, most stones that are under 5 mm pass spontaneously, and individuals are advised to drink at least 2 liters of fluids per day until the stone passes. Once it passes, they should retrieve it and send it to the hospital laboratory to determine its composition. Finally, there are renal stones. For asymptomatic renal stones, active surveillance is done once a year using urinalysis, creatinine, and an abdominal ultrasound. For symptomatic renal stones smaller than 20 mm, ESWL or URS can be done. For symptomatic stones that are over 20 mm, PCNL is done. For stones that are located in the lower pole calyces and are under 10 mm, ESWL or URS can be done. For symptomatic stones that are located in the lower pole calyces and are over 10 mm, PCNL is done. With struvite stones, urinary tract infections need to be treated with antibiotics. Now, after retrieving a stone, its composition is analyzed in order to determine what kind of stone it was. If the stone composition remains unknown, then after 1 to 3 months from the acute episode, 2 24-hour urine collections should be obtained to determine urine volume, pH, and urinary excretion of calcium, uric acid, citrate, oxalate, sodium, potassium, and creatinine. This helps identify risk factors for stone formation and prevent further stone episodes. General measures include higher fluid intake in order to produce at least 2 liters of urine per day, less than 1 tablespoon of salt per day, less animal protein in the diet, less oxalate-containing foods like French fries, dark chocolate, or black tea, and finally, more fruits and vegetables in order to raise the level of citrate in the urine. If there's high urine calcium, then a thiazide diuretic like chlorthalidone is given to lower urine calcium. If there's a high urine calcium, then the serum calcium is checked. If the serum calcium is high as well, then there may be an underlying hyperparathyroidism. If there's high urine uric acid and general measures don't lower the levels, then allopurinol is given. Finally, to prevent cystine stones, urinary alkalinization can be done with oral potassium citrate. A follow-up with a 24-hour urine collection is done after 6 months of dietary and medical therapy. Alright, as a quick recap. The best test for identifying a kidney stone is a non-contrast CT scan, where calcium oxalate and calcium phosphate stones are radiopaque, struvites have a lower density than calcium stones, and uric acid and cystine stones have an even lower density. The ultrasound can identify renal stones, or proximal ureter stones, and hydronephrosis. Acute renal colic is treated with NSAIDs or opioids. If there are obstructive stones and there's also fever, or if there's bilateral obstruction, like when both kidneys have stones with high levels of creatinine, or if there's an obstruction on a solitary kidney, specifically when there's a single functional kidney, then percutaneous nephrostomy or ureteral stenting is urgently done. Most stones that are smaller than 5 millimeters pass spontaneously. Ureteral stones that are smaller than 10 millimeters with controlled symptoms are initially managed with MET, increased fluid intake, NSAID, an antiemetic, and an alpha blocker for 6 weeks. If during this period the individual has uncontrolled pain and fever, then options include ESWL and URS for proximal ureteral stones. URS is done for stones that are located in the mid and distal ureter and also for stones larger than 10 millimeters. If URS fails, then PCNL, laparoscopic or open surgery is done. Asymptomatic renal stones need active surveillance once a year using urinalysis, creatinine levels, and abdominal ultrasound. Symptomatic renal stones under 20 millimeters are treated with ESWL or URS. When they are above 20 millimeters, PCNL is done. For lower pole calyx stones under 10 millimeters, ESWL or URS is done. And for lower pole calyx stones over 10 millimeters, PCNL is done. Stone composition needs to be determined in order to correct specific risk factors and to prevent recurrence.